And this is the period where they talk about insulin resistance. What you get is this compensatory hyperinsulinemia, which keeps the blood glucose down, and that's why you don't see this sudden spike. And then at some certain point, you get this second phase where things just shoot up. And that's that loss of compensatory hyperinsulinemia, and they call it pancreatic burnout. What they say is that your beta cell has basically been working so hard, it's burned out, so you can't produce the insulin. Even though your insulin levels are much higher than normal, they're not high enough to keep the lid on the glucose, and therefore the blood glucose shoots up. You blow past whatever diagnostic criteria you have for type 2 diabetes, and this is what happens. So what they're postulating is that, and this is the traditional thinking, is that this is why it's an irreversible disease, because you have this pancreatic burnout, and you can't reverse this part. And they're two entirely different disease processes. One is high insulin resistance, the other is a sort of scarring of the pancreatic islet cells. So they have nothing to do with each other, and yet they only occur sort of one with the other and never with any other disease, which is a little bit strange. But that's why they say it's irreversible. And of course, this is what you see. So you see, if you look at fasting insulin levels, you see this hyperinsulinemia. So as you go from the spectrum of normal lean to obese, to obese with type 2 diabetes, you see that the insulin levels are going up and up and up, and that's that insulin resistance and / hyperinsulinemia. And this is the glucose tolerance test compared to the insulin. So here's the glucose, here's the insulin, and this is what we know as you go from the spectrum of normal, lean, to obese and type 2 diabetics. What you see is that at first, this is your insulin levels. It's in the solid circle, so it's going up and up. And then at some certain point, even though your glucose is going up, the insulin actually starts to drop. So yes, your insulin is higher than baseline, but it's not as high as it was before. And that's that loss of compensation, and that's pancreatic burnout. And the big change is that for years, we said that type 2 diabetes is chronic and progressive because of this progressive burning out of the pancreatic islets. But in 2021, the big change was that this was actually a reversible disease and not progressive. So this is the American Diabetes Association, and what they used to say was exactly this. This was on their, it was under Diabetes Basics, that type 2 diabetes, for most people, is a progressive disease. They got rid of that. In 2018, they removed it. It's gone. You can't see that anymore. And instead, what they have is this. In 2021, they came out with the diabetes remission criteria, which of course implies that remission is possible because you don't define it if it's impossible. So it's a huge change because if this is a disease that can be put into reverse, that's what we should be doing. And what I'm going to talk about is the pathophysiology behind why we think this is so. So if you think about reversal of type 2 diabetes, people think that it's impossible, but we've actually shown it for many, many years. So for example, you can take bariatric surgery. It reverses type 2 diabetes very clearly. This is data from 1992, so this is from 30 years ago. If you do bariatric surgery on people, the blood glucose falls almost immediately, and the results are, for the most part, very long-lived, so going out 10 years or so. So this is the data from the New England Journal of Medicine. This was, again, Roux-en-Y gastric bypass versus intensive medical therapy, which, of course, at the time was mostly insulin and sulfonylureas. You can see that over time, if you just give medical treatment, they stay on the same number of medications, and they don't lose weight. But if you do surgery for these people to make them lose weight, then the blood glucose falls immediately. So they get off of a lot of medications. They come down right away. So remember, this is long before they've lost weight. So, at a month or 2 months, they may have only lost 20, 30 pounds if they weighed 500 pounds. That's not a lot from a percentage standpoint. But the blood glucose has gone down. They're getting off all their meds. Even out to a year, a lot of them are still continuing to get off all their meds. And yes, this is a drastic situation, but the point is that this is a disease that is reversible. That's very clear in these studies. It's that we didn't focus on the right things. We focused on giving more meds, but giving more meds is never going to work. If they lose weight, their type 2 diabetes goes in reverse, which we always knew, of course. And you don't have to cut out pieces of the stomach. You can do gastric banding, and you'll see exactly the same results. The blood glucose falls immediately, like even within a week. We see that fasting is also something that has helped people reverse type 2 diabetes. And this is, again, not new. So this was written by Dr. Elliot Joslin in 1916, so this is more than 100 years ago. And he wrote in the CMAJ that temporary periods of undernutrition are helpful in the treatment of type 2 diabetes, will probably be acknowledged by all after these 2 years of experience with fasting. So he thought it was so obvious that you wouldn't even need to do a study. And this is probably the most famous diabetologist in history who is writing this 100 years ago. Because for type 2 diabetes, if you lose weight, yes, your diabetes will go away. And he thought it was obvious. Then, of course, what happened was that they discovered insulin. Everybody forgot about dietary treatments, and we went ahead and gave a lot of insulin to people. And if this was in the BMJ, as an article, a case report I wrote, and it was under the myth exploded that you could actually reverse type 2 diabetes. And they did an article in Reader's Digest, and these are some of the people who did reverse their type 2 diabetes just by using intermittent fasting. You see, of course, that a lot of them, they lose a lot of weight. When you lose weight, your type 2 diabetes goes in reverse. And very low carbohydrate diets can also put people into remission. This is from the American Diabetes Association. So again, this was only published in 2020, and this is a consensus report from the ADA, and when they're talking about eating patterns, what they say is that reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia. That is, it's not some kind of fad diet that has no scientific bearing. It is, in fact, the diet with the most evidence for reversal of type 2 diabetes. And this is a study from Dr. David Unwin in the UK, and he has been using low carbohydrate diets in his practice. He just gives people a handout and he tells them, cut your carbs down. So this is his experience over 6 years. And what's interesting is that over a period of 23 months, he had a type 2 diabetes remission rate, drug-free remission, of 46%. So almost half of his patients that chose to do this not only came off all their drugs, but had an A1C so low that they were considered no longer diabetic. Half of his patients. If you do the same thing with pre-diabetics, their A1Cs go down to a level that they're considered normal, not pre-diabetic, in 93% of cases. So this is all real-world experience and backed up by, the scientific data. It is a disease that can be put into remission in half of our patients, and that is a huge number of patients. It's going to have a huge impact on your practices. And there was no threshold above which it was not successful. So even if you had A1Cs up in the 15% range, they still came down when you restricted carbohydrates. So compare that. So these are strategies that reverse type 2 diabetes. We know it, we've seen it, everybody's done it. In fact, everybody knew it already. So if you had a patient who said, well, hey, I had, lost 50 pounds, my diabetes went away, I got off metformin. You'd say, great job. You wouldn't say, hey, you're such a liar, right? It's chronic and irreversible. What are you talking about? No, you knew it. Everybody knew it. Every patient knew it. Every doctor knew it, that this was a disease that could go into reverse. Yet, for years, we focused on things that just led to progression. That is, giving more insulin, giving more sulfonylureas, giving a low-fat diet. None of that actually made any difference. Things just continued to get worse. So what was the difference? And there's two key concepts when you understand what insulin resistance is, what type 2 diabetes is. That is the underfill versus the overflow, and looking at the blood glucose versus the whole body glucose. And these are concepts that I think about a lot as a nephrologist. So what is insulin resistance? What is this disease process that we're all worried about? Well, this is how we think about it. This is the classic teaching, which is a lock and key paradigm, right? So this is normal insulin metabolism. You have a cell here, You have glucose, you have insulin. Insulin sort of fits like a lock and a key. It brings it opens up your gate, and glucose goes into the cell to be used for energy. So when you have insulin resistance, people say, something's going on here, there's a problem. Now you can sequence the receptor, you can look at the insulin. Insulin molecule is normal, insulin receptor is normal, so maybe it's like a piece of gum or something that's in the lock and it's sort of screwing up the key. So when that doesn't happen, what happens is that you don't get the glucose, it piles up outside the cell, which is what you see. And inside the cell, presumably, you have internal starvation. That is an underfilled cell. You have no energy here. We don't know what causes it. Something causes it, but it causes this insulin resistance, which leads to compensatory hyperinsulinemia, which then drives the glucose in. Now, the problem with that is that in this situation of internal starvation, this is exactly, of course, the situation you see in type 1 diabetes, but in that case, of course, you don't have insulin. But you get the same low intracellular glucose, and this is what untreated type 1 diabetes looks like. So you see this person is super, super skinny, cannot gain any weight. No matter how much food you give this poor girl, she will not gain any weight because insulin is necessary for that energy to go in, for the glucose to go in, for you to store energy. You need insulin, so she cannot store energy. She gets thinner and thinner until she dies. And then, of course, you give her insulin and she goes back to normal. So that's internal starvation. But this is type 2 diabetes. Phenotypically, it looks nothing like that internal starvation. It's a real stretch with this person with all their abdominal obesity, their big fatty liver, to say that this is a state of internal starvation. I can't see it, and it looks nothing like real internal starvation. So that's a bit of a problem. So when you're thinking about the resistance, what you're talking about is that you have all this glucose outside the cell, and it cannot go in. But there's two possibilities as to why it cannot go in. You could have a malfunctioning insulin receptor, that gum in the lock and key, or the other possibility is an overflow problem. That is, your cell just has too much glucose, and that's why it can't go in. So you have, the primary problem is not just the glucose in the blood, it's the glucose in the whole body. So if you have a situation where you have high insulin levels for a long time, you've been spending decades just shoving glucose into the cell. It keeps going in and in and in. And now there's just too much. And that's why it's piling outside. You can't fill it in. It's an overflow problem. That's a possibility. So it has real implications because the way you treat it is going to be completely opposite. In the internal starvation mode, you're going to give more insulin because that's the right treatment. Same as type 1 diabetes. That's the right treatment. In type 2 diabetes, if it's an overflow problem and you have too much insulin, giving more insulin doesn't solve the problem. You're just going to keep shoving this glucose into this overfilled cell. And the minute you stop giving the insulin, it's just going to come back out. And you're not going to make the problem better. You're going to make the problem worse because you're filling this overfilled cell. So if you think about it, it's sort of like a suitcase, right? We're putting clothes in. It's going in, no problem, no problem, no problem. All of a sudden, you can't put those clothes in anymore. You can't put in those last 2 T-shirts. It could be a problem with the locking mechanism, or it could be that your suitcase is full, right? Both are possibilities. Think about it like this. If you have a train, which is like your cell, and you have glucose, which is like the people standing on this platform. Normally, insulin opens the door, people go in. If all of a sudden you see people piled up back out here, 2 possibilities. 1 is the door didn't open. 2 is that there's just too much people inside. So giving more insulin and shoving people into that car doesn't make it better. It makes it better temporarily because there's less people here, but it makes the overall problem worse because you're overfilling an overfilled train already. So how does that work from a biochemical standpoint? Well, it's very simple, really. And again, if you think about what happens to glucose, it undergoes a sort of very stereotypic process. So glucose undergoes this process called glycolysis, which turns into pyruvate. Amino acids come in here and fatty acids come in here. And essentially you go from pyruvate through pyruvate oxidation to acetyl-CoA. And acetyl-CoA is kind of the sort of baseline. So fats can do it, amino acids can do it, glucose can do it. So any of those can do it. And from there, you go through the citric acid cycle, and you generate ATP, which is cellular energy. Now, you can't just keep on doing this forever, because if you have too much ATP, it's toxic. You have too much energy, right? It's just like if you have too much heat, you just burn down. Your cell doesn't want to do that, so you don't want too much ATP sitting inside your cell. So if you're shoving in all this glucose and you're generating ATP, it's going to naturally put a stop on all of these processes: the citric acid cycle, the pyruvate oxidation, and the glycolysis, which is going to lead the glucose levels inside the cell to go up because you don't want to move your glucose into ATP. So when you're backing up your glucose, your internal cell glucose is going up, what happens when you open up that gate? So insulin attaches to its receptor, opens up the GLUT4, the gate is open, but it can't go in because this depends on facilitated diffusion. You need a concentration gradient between the extracellular glucose and the intracellular glucose in order for this to go in. If you've just backed up all your glucose, that glucose just backs up out the door. And that's exactly what you're seeing with insulin resistance. So let's follow this through logically. So what happens to that excess glucose? So now you've got all this glucose sitting inside your liver cell. Your liver doesn't want all this glucose. It doesn't want ATP. It can't generate that ATP. So you activate this process called de novo lipogenesis, which is here. And essentially you're taking glucose, going through this process of acetyl-CoA, citric acid cycle, and then you're eventually creating triglycerides, which is fat. That's what de novo lipogenesis means. It's de novo, which is from new, lipo, which is fat, genesis, the creation. It's the creation of new fat from your glucose because you have too much glucose. Your body is busy turning that glucose into fat, and that's the reason almost all of the type 2 diabetics have a big fatty liver. There is no internal starvation going on. We know in type 2 diabetes that de novo lipogenesis is going crazy. So you're generating a lot of fat from glucose. If you were to say that this is all a problem with internal starvation, a malfunctioning insulin receptor, if you don't have any glucose inside your cell, how are you going to make triglycerides from the glucose that does not exist? Right? It's like building a brick wall with no bricks. You can't do it no matter how many carpenters you have. So if you have no glucose inside the cell, you cannot generate fat to give you fatty liver, which we know clinically that most of these patients are going to have. So again, let's follow this through. So you're generating all this new fat in the liver because you had too much glucose, too much insulin. The liver don't want to hold on to that fat. It's not supposed to be stored in the fat. So it tries to get rid of it. This is the process of cholesterol transport. So you take the fatty acids, package it with some cholesterol and some lipoproteins, and you send it out as very low density lipoprotein. Goes out into the blood, right? So you've got all this excess fat. Your liver is trying to dump it out. It's trying to get rid of it. So it goes into the blood. So you see very high triglycerides. The triglycerides bring those fatty acids in the blood. You activate lipoprotein lipase, and it goes into fat cells. That's where you get the abdominal obesity that you see in type 2 diabetes, which then goes to intermediate density lipoprotein and lowers the HDL. So what you see is high triglycerides, low HDL, which goes to LDL, and that may go up as well. But what you're seeing now is, okay, here we have a process of hyperinsulinemia, too much insulin, too much glucose, overflow situation, not underfill. You're going to get abdominal obesity, you're going to get this insulin resistance, you're going to get high triglycerides, low HDL, and you're going to get high blood pressure because insulin is an antidiuretic hormone. So it causes your kidney to retain salt and water, which is going to increase your blood pressure. Well, what are those 5 things called? This is literally the definition of metabolic syndrome. It all goes together. Why do these cluster of things all go together? Is because they have the same underlying cause. They're all hyperinsulinemia. Your body is trying to get rid of that excess fat by throwing it into the abdomen. It's trying to block more glucose going in, so you get glucose out the cells. You got the triglycerides, the HDL, and the hypertension. It's all part and parcel of the same process. So again, if we compare the two ways of thinking, and again, this is the underfill. So you say that the main problem is internal starvation, some kind of malfunction here. What causes malfunction here? Well, nobody knows. After 50 years, nobody has any clue what this is. It's some mystery villain that has been eluding scientists for decades. Even as it causes a worldwide epidemic, we just don't know what's causing this malfunction. Some people say it's, fat, and some people say it's inflammation, and some people say it's this and that. Well, that's not very satisfactory. So this entire hypothesis, which is some mystery, causes insulin resistance, causes hyperinsulinemia, and this intracellular starvation is going to make some predictions in terms of clinical medicine. This will predict what we're going to see in clinic. It's going to say, no, you're not going to have fatty liver. It's going to say, no, you're going to be skinny, not fat. It's going to say, hey, you lose weight, it's not going to make any difference because you have internal starvation. It's going to say insulin makes things better. That's the right treatment. And the pushing the glucose from the blood inside the body will make things better. And of course, every single one of these predictions is completely incorrect. We know this since 2008 with the Accord study. That is, when you give people lots of insulin and sulfonylureas to make that blood glucose down, you can bring it down, but you can't make them better. In fact, you might make things worse. That's why the A1C targets have gradually gone from 6% to like 8%. And think about this for a second. If your problem is that you've got too much blood glucose and you give them lots of insulin and shovel all that blood glucose into the liver, like you never got rid of the glucose, what's going to happen? Well, your liver is going to turn it into fat, which means you're going to get weight gain. If you get weight gain, your type 2 diabetes gets worse. So you're making the blood glucose better, but you're making the type 2 diabetes worse. No wonder you didn't have an effect. And it wasn't shown in just this study. Of course, every other study does the same thing. This was the ADVANCE study, which showed that even after 10 years, you couldn't show any difference to lowering blood glucose by giving more medications. And compare that to this other way of thinking, which is this is an overflow problem, right? The problem is too much insulin, too much glucose. This resulted from dietary changes. We're eating more refined carbohydrates. We're eating more often. We're eating more, which is going to lead to hyperinsulinemia because insulin is a nutrient sensor. That hyperinsulinemia means you're shoveling all this glucose into the cell. That's going to overflow. Your glucose is going to go back. You're going to get this so-called insulin resistance, which is going to cause compensatory hyperinsulinemia, which is ultimately destructive because, of course, shoveling more glucose in is not going to do any good. So this is also going to make some predictions in terms of clinical medicine, which is that you will have fatty liver. You will have obesity. If you lose weight, all of this, if you get rid of that, the overfilled adipocyte, your type 2 diabetes will go away. And yes, it does. It's going to predict that insulin makes things worse, which it does, and it's going to say that pushing glucose from the blood into the body does you overall no good, which is what the insulin did. And of course, every single one of these predictions, from a clinical standpoint, which is the most important because that's what our patients are seeing, is correct. It's not a new concept. This was from the 2011 Banting Lecture, which is the sort of scientific achievement award for the American Diabetes Association. This is the new thinking from 2011. The problem is not that you have a malfunctioning insulin receptor. The problem is that you have too much insulin. That is the underlying problem, too much insulin, which is then linked back to dietary changes, which are, we can track those dietary changes. We know there's been dietary changes since the 1970s. So it's not some mystery as to what's happening. We can track it back and we can see it. And the treatment paradigm, of course, is completely different. Instead of giving more insulin, you want to lower the insulin because you have too much insulin already. And you got to treat the whole body glucose, not just the blood glucose. moving the glucose from the blood into the liver does you no good because it's still there. It's sort of like taking garbage and just throwing it under the sink. It doesn't do any good. You can't see it anymore, but it still stinks. And that's the problem. When you take this glucose and just put it into your body and turn it into fat, you never got rid of the glucose, so it's still there causing as much damage as if you didn't. So how are you going to lower the glucose? Well, we have drugs that will do that now. And this is, for example, canagliflozin. So as an SGLT2 inhibitor, it's going to make you pee out some glucose. If you pee out the glucose, then your insulin is going to go down, which is what this shows. And that's just sort of basic. And of course, then you get to studies like the EMPA-REG study, which is a study where they used SGLT2s, and what they found was that the A1C lowering was pretty minuscule. In EMPA-REG, the A1C reduction was only 0.4, which is sort of meh. It's like, yeah, it's not very good, right? If you give insulin, you can get those A1Cs down 1%, 2%, 3%. You can't really do that with this. So there's almost no benefit compared to some of the stronger stuff on blood glucose lowering. But the important thing is that you're dumping glucose out of the body. This is all-cause mortality, down by like 32% for a barely noticeable drop in your A1C. But they got the treatment paradigm right, because you're treating the overflow, not the internal starvation. And you can look at a drug like semaglutide. So again, it makes you not want to eat. So this is semaglutide. You see total energy intake about 700 calories a day less. And if you're eating less, insulin is a nutrient sensor. If you're eating less, insulin is going to go down. So you see proinsulin and insulin go down with semaglutide, which is not a surprise. And of course, you lose weight. As you lose weight, look at the end organ endpoints. So this is strokes and MI down by 26%. Like, that's a huge benefit for semaglutide that you never saw before with insulin or sulfonylureas or even metformin. Nephropathy, where we've had no new drugs for renal protection since the ACE inhibitors in the 80s, huge protection, like a 36% reduction in new nephropathy, like almost unimaginable benefits that you never used to see. So the point is that you got to treat root causes, okay? So if you have a disease, like a bacteria, it can cause an infection, which causes a fever. This is the symptom. You can't treat it here. If you give acetaminophen for an intra-abdominal abscess, that's symptomatic treatment. It might make you feel better, but it doesn't make the actual disease any better. You actually can't make it better until you treat the cause of the disease. So the same thing occurs in type 2 diabetes and obesity as well. So your problem is hyperinsulinemia. You have the obesity, which is sort of a marker for hyperinsulinemia, which is causing your type 2 diabetes, which is causing your blood glucose to go up. That's the symptom. That's not the disease. So you can't treat the blood glucose because you're not actually treating the disease. You got to treat it here. If they lose weight, their diabetes goes away, and then their blood glucose comes down. What happened was we mistook the symptom for the disease. So for the past 30 plus years, we were treating it symptomatically. We weren't treating the root cause. We were treating what we could see. We were treating the fever and not the infection. The disease was hyperinsulinemia, not hyperglycemia, which is why lowering the blood glucose ultimately did not do any good. And that was the lessons of the Accord, the Advance, the VADT, all those very expensive studies from 15 years ago. And even looking at it from a simplistic standpoint, this is what happens during type 2 diabetes. We know this. Insulin goes way up before your blood glucose goes up. Then, of course, insulin starts to go down and glucose goes up. So when you look at this entire disease process, do you think it's the insulin that's the problem or the glucose that's the problem? And for years, we said it was all about the glucose, all about those A1Cs, all about getting the glucose down. And that's why we said, well, we can't treat it. it's chronic, it's progressive. It was never progressive. We were just treating the wrong thing. We should have been treating the hyperinsulinemia. Instead, we're giving insulin. And again, it's exactly the wrong thing. It puts you into this downward spiral because you treat this with insulin. Insulin leads to weight gain, and it's just a vicious cycle. Take more insulin, gain more weight. Gain more weight, type 2 diabetes gets worse. So guess what? You take more insulin. Then you gain more weight. And it keeps going. And this is the way we used to treat it. This is the way I treated it for years. And it wasn't the right thing. Nobody got any better. And then they got their heart attacks, and then they went on dialysis. And we said it was chronic and progressive, there's nothing we can do. But there is something we can do. If you look at the treatments that reverse type 2 diabetes, the bariatric surgery, the fasting, the very low-carb diets, compared to the treatments that lead to progression and worsening, what you see is that these things all increase insulin, and these things all decrease insulin. So there's a very big difference between how you're going to treat it if you understand that the root cause is actually the hyperinsulinemia. It's a disease of too much insulin, and that's why it doesn't work. So then we get to the second problem, which is what's happening in the pancreas, because we know that the insulin levels go way up, and then they start to drop. So if it burns out, then yes, it is a chronic and progressive disease. Is it really burned out? So this is called the Counterpoint study. It was done by Dr. Taylor in the UK in 2013. And what he did was put people on a very low-calorie diet, 800 calories a day for 8 weeks. And the fasting blood glucose came right down. So immediately came down from, 9 or 10 to like 6, normal, almost immediately. So very, very good. When you measure the liver fat, you can see this is the sort of normal control. You see that people with type 2 diabetes have fatty livers. That's not a surprise. As you sort of give them very little to eat, they're going to use up some of the fat in the liver, which is good. So over time, the fat in the liver comes down, even down below baseline. And as you get rid of that liver fat, so it's just like emptying out that suitcase, right? You're taking out that excess glucose, then hepatic insulin sensitivity is restored. You don't see the insulin resistance anymore. It goes away because you unloaded that cell. And this is hepatic glucose production. This is baseline. So again, you're getting too much hepatic glucose production. That's the whole problem with insulin resistance. It goes away. So insulin sensitivity goes right back down to normal when you get rid of the fatty liver. But what's happening to the pancreas? Well, turns out that when you look at the pancreas in type 2 diabetics, not only do they have big fatty livers, they have big fatty pancreases as well, because the liver's been exporting all this fat. And you can see it on ultrasound. In fact, a lot of the radiologists around my areas are reporting fatty pancreas all the time now. This is control, and this is the fat, triglyceride content of the pancreas. And over time, so it's a much slower process, but you can see that the fat in the pancreas slowly goes down, but it takes a lot more time than the liver, because remember, the liver is right there. When the body wants energy, it's just going to pull it out of the liver because it's right there. It's a lot harder to pull it out of the pancreas because it's got to go through this whole process of reverse cholesterol transport. But what happens to the beta cell? This is the beta cell function. So how much insulin is this beta cell producing? This is baseline, so it's not producing as much insulin as it should be, but as you get rid of that fatty pancreas, it goes back up. So that drop in pancreatic insulin production was not irreversible. That is, the pancreas cell was not burned out. It is in very late stages, but for most people, it was just clogged up with fat, which means that it's a reversible condition. The pancreatic cell has reversed its defect. And so this is the twin cycles hypothesis of type 2 diabetes, which is very important, again, from Dr. Taylor and from the American Diabetes Association. I'm going to take it through it slowly. Essentially, there's two cycles. There's a liver cycle and the pancreatic cycle. And what you have is you have a diet which leads to very high insulin levels. So you're eating all the time, you're eating a lot of refined carbohydrates. This gives you the fatty liver, right? So you have too much insulin, you're shoveling all this glucose into your cell is turning it into fat, you get fatty liver. which leads to this hepatic insulin resistance, which is that overflow, which leads to higher insulin levels. But that's only part of the story, because there's another cycle. As your fat, builds up in the liver, it's going to export it, and you're going to get fatty pancreas. So that's going to clog up your pancreas, and it's going to lead to this reversible beta cell dysfunction, which is, again, going to lead to high blood glucose and insulin production again. So you have a liver cycle, and you have a pancreatic cycle. And what's important about it is that now type 2 diabetes with its two phases are not two distinct diseases. There's not two different pathophysiology. There's not one thing that causes insulin resistance and then some sclerotic process of burnout. Both of these are just diseases of ectopic fat deposition. There's a bunch of fat where it's not supposed to be. It's the same underlying pathophysiology. It's a sort of uniting theory of type 2 diabetes. So how are you going to impact this? Well, the body figured this out a long time ago. If your whole problem is that you have too much glucose leading to too much insulin, well, you dump it out in the urine. Just dump it out. That's why you have a renal threshold of glucose. When your glucose levels goes too high, your body cannot absorb anymore, and you get glucosuria. It wasn't an accident. The kidney is limited to a certain level of blood glucose. Above that, the body is trying to protect itself from this glucose toxicity. And that's what the SGLT2s do. It enhances that sort of protection. And that's why you see such incredible protection in the end organs, in the kidneys, in the heart, for heart failure, for all of that, because you've got the paradigm right. So these two phases are not separate and distinct entities. They're not separate and distinct diseases. That's why they're always linked to each other, because they're actually part of the same disease. It's the same, it's the same underlying process that's causing both of these problems. So again, if you think about the drug treatments, now you can say, okay, well, let's think about two things. First of all, one is that the disease is hyperinsulinemia, not hyperglycemia, and we got to treat the whole body glucose, not the blood glucose. So there's good drugs for that. We know that SGLT2s and GLP-1s are very good. The studies are all excellent. The blood glucose, the effect is sort of meh for SGLT2s. It's pretty good for SGLP-1s. But it decreases the insulin, which decreases your weight, decreases the whole body glucose, and what are the CV outcomes? Almost stuff we've never seen before in terms of renal protection, cardiac protection. If you look at the bad stuff, like just didn't do very much, the DPP-4s and the metformin, they had pretty good blood glucose control. It was not bad, but it was sort of neutral on the whole body glucose. If you take metformin, you're not getting rid of glucose. Remember, with the SGLT2s, you're peeing out the glucose. On the GLP-1s, you're not putting glucose into the system. So the whole body is having less glucose. That doesn't happen with metformin or DPP-4s. So you have pretty good blood glucose control, but pretty neutral on the whole glucose, neutral on the insulin, neutral on the weight. So is there any benefit? Hard to tell. Not very many studies. I mean, you can go back to the UKPDS from like 40 years ago, but nothing really since then. And then there's the stuff that's just ugly, which is like the insulin and the sulfonylureas, TZDs too. But the whole blood glucose goes up because you're giving insulin. People are gaining weight, their insulin's going up, they're gaining weight, and if anything, they're making outcomes worse. Because again, if you're just making things worse, you're gaining weight, your diabetes is getting worse, you're taking more insulin, well, patients knew it. They're saying, hey, what's going on here? All I'm doing is taking more and more and more insulin over these years. And you know what? They were exactly right. That was never the right treatment. What we should have focused on is treating the insulin. Because remember, you can't treat a hyperinsulinemic state with more insulin. It never made sense. It's like treating an alcoholic with alcohol. Like, yes, you will have less DTs, your symptoms will get better, you'll stop shaking, But your disease, your alcoholism, is going to get worse. If you have too much insulin, why would you give more insulin? Do you treat a hyperthyroid patient with more thyroid? I don't think so. So why would you treat a situation where you know you have too much insulin with more insulin and sulfonylureas? And then we wonder why it's not getting better, because the treatment was not correct. And the whole point is that, yes, we have great drugs to do it, but you don't need drugs to do that, because your ultimate root cause is back here in the diet. Because you can use low-carbohydrate diets, because we know those reverse type 2 diabetes. And you can use intermittent fasting. If you don't eat, insulin levels are going to go down. The whole thing about insulin, about fasting, is that it's very simple. If you don't eat, your body still needs a source of energy. The most available source of energy is your blood glucose. So it's going to use up that blood glucose. That's it. And so now you can use up that blood glucose. Glucose is going to fall. You didn't need drugs to do it, because you could do it naturally without all of those drugs. Is it fun? No. But is it effective? Yes, it is effective. That's the point. Both of these treatments are free and available. We can do this. We just have to change the way we think about type 2 diabetes. And the key takeaways, really, is that this is a reversible disease. Okay, that much is clear, has always been clear, but because we thought it was all about pancreatic burnout, we called it chronic and progressive, but it wasn't. It's a reversible disease, so that's the target that we should be aiming at for every single one of our patients. Is it going to happen? No, but we should be aiming for that. The key treatment, other than the drugs, is the diet, because that's the root cause of it. You got to treat the cause and not the symptoms. If you treat the symptoms, it's not going to affect the disease process. You treat the diet, they lose weight, that diabetes gets better. Nothing difficult about that. The problem is hyperinsulinemia, which causes the insulin resistance through this overflow mechanism, as opposed to this sort of outdated underfill mechanism, internal starvation, that we all thought it was. This lack of insulin, relative lack of insulin, is a term that used to be used. But total insulin was way too high. And you got to treat the whole body glucose. So if you're limiting the glucose that's going into your body, such as with low carbohydrate diets, or you're increasing the burning of the glucose, such as with intermittent fasting, you're going to be able to reverse type 2 diabetes. And with that, we're sort of entering this whole new era of thinking, because if you can get people to lose weight, if you can reverse that type 2 diabetes, you're going to have a huge impact, because if you think about it, there's so many diseases that are impacted. Your cardiovascular disease, heart attacks, strokes, cancer, and then type 2 diabetes, which causes blindness, which causes amputations, which causes infections, which causes kidney disease. So all of those ultimately come back to diet and lifestyle. And we all grew up in an era where we have a certain way of looking at medicine. That is, the acute care theory of, way of looking at medicine is that people get sick, you come to the doctor, I give you a drug, you get better. Worked well with antibiotics. So, you had an infection, I gave you a drug, you're all better. The problem is you can't translate that model into 21st century medicine, where a lot of our diseases are chronic and dietary. Because look at what kills people. Heart disease and cancer, both of them huge risk factors of diet and lifestyle. All of the other diseases, even COVID, we know that if you're overweight, that it takes a much bigger toll on you. So it affects every single facet of medicine, because all of medicine has moved away from sort of acute medicine like infections and, parasites and all this stuff where we needed the right drugs, to this sort of chronic diseases, because that's what affects people now. And you can't just give a drug for a chronic disease. It doesn't work like that. You have to get back to the root problem, which is that weight. And when you can do that successfully, that's when you can make a difference for your patients. And that's how you can reverse type 2 diabetes.